are the hospitals actually fuller than they were? Well, they are. And the difference is treating for a COVID patient is very different than treating for an influenza patient. The isolation that's necessary, the amount of resources that are necessary are extremely different. So it's much more resource hungry to treat for a COVID patient than it is to treat for an influenza patient. And the direct effect of this is something that we've never seen in all of, even if you look at our worst influenza cases, our H1N1 flus from 2010, I think it was, all the big flus that we've never had to stop operating people. I've never had to take a nurse from the OR and bring her to work in my ED. We've never had to do this.
Hello, everyone. Welcome back to the Ozeki Journal Club. Today we have a very special guest, Dr. Massimiliano Iseppon, who will, so Matt, why don't you introduce yourself real quick?
Hey, I'm first and foremost a good buddy of Perry's, and I'm also a emergency physician at Maisonneuve-Rosemont Hospital and a fellow in critical care ultrasound.
Thank you. So yeah, we thought, because the last couple of episodes we had Professor Farrow give us one perspective on COVID and the measures, we'd have Dr. Iseppon here, Mass, to give us a different perspective, so we can try to understand first and foremost. I guess the goal would be to see which measures that have been implemented in Quebec specifically are justifiable, if any. So since Mass has been on the front lines, we wanted to hear his perspective. So maybe we can start by asking him, what is different from pre-COVID to during COVID in terms of healthcare, hospitalizations, all this kind of stuff?
It's a loaded question, but the answer is actually pretty easy. I think the difference is everything is different. I mean, I graduated in 2017. I did my fellow in 2017, 2018, and I started to practice medicine. For the first 2 or 3 years of my practice, I practiced the exact same way I had learned to practice. I reasoned the exact same way I learned to reason. My differentials were always the same. They obviously they always change because medicine evolves, but they, the structure or the baseline of how we practice medicine, was relatively similar to how I was trained during my residency. I can't say that in the past 2 years things have been the same at all. I mean, we've changed not only our approach to medicine, our approach to preventative medicine, our approach to how we just physically deal with patients. Our interactions are different. Our interactions with the way we address and the way we examine people is different. Our approach to patients is different as well from our personal security standpoint. And I've said this on numerous occasions before. I've had to completely relearn how to practice medicine over the past 2 years because things are completely different. And I think a lot of us are just hoping and waiting for it to get back to the way it was before.
So maybe you can ask, so why are they different? Are they different because, so obviously they're different because of COVID, but is COVID, are you more scared of COVID, or is this a government telling you to be more careful? Is this you yourself saying, oh, I should do things differently because I'm personally scared of what's going to happen? What is the reason for why things are different?
So I think that's evolved over time. I think initially we went back to work and there was a lot of uncertainty regarding what the irony was that I actually had a two week grace period, because when COVID actually hit, I was in France and I was on a ski trip and I was lucky enough to be there. But when I got back, I had to be quarantined for 2 weeks. But I saw my colleagues go through the initial steps of learning how to deal with this new thing that was going to be omnipresent in everything that we did. I think initially a lot of what we did differently was based on fear, but not fear that was provided by the government. It was more fear of the unknown. We were dealing with something that we had never dealt with before. We were dealing with something that was potentially significantly deadly. Our prior experiences with SARS viruses, dating back to Toronto in the early were significant, and were particularly scary and very, very deadly. So we had to approach this as a worst case scenario situation. And I remember, some of my colleagues coming into work scared, crying, not knowing what to expect, not knowing what to do, being completely irrational from a medical standpoint. I think that what initially came out were feelings that were very personal, that were driving this, a personal fear of what's going to happen to me, me being on the front lines, what's going to happen to my family. I have kids at home. Am I exposed? How do we catch this? How does it transmit? What's going to happen? Are we going to be more complicated because we're so exposed? Are we going to be sicker if we do catch it? A lot of that stuff was based and driven by uncertainty. I think over time, we've learned to live with COVID, and we've learned to practice with COVID. So I don't necessarily notice these differences as much as I did initially. I can say, however, that now what's driving us is more so prevention and patient protection than it is us being concerned for our own personal health. Obviously, there's always that little, voice behind our head that every time we sort of, because when you work with COVID, you sort of, it's like anything else, right? It's like, just like you guys initially probably were very safe and you wore your mask all the time, washed your hands 16 times a day. Well, that, dwindles and fizzles out over time. It's the same thing with us. I work in an environment where I'm constantly faced with patients. We're not at the initial stages of COVID where nobody would come to the emerge anymore. Now, emergency rooms are full again. We never know when we're exposed, and when, especially now in the past few weeks, when we're, surprise exposures are very common. So there are a bit of lapses in our own personal protection. What guides our behavior now is more protection of the patients, protection of the vulnerable, and more so even protection of the healthcare system as a whole, and of our staff, and being able to actually provide care for patients without being entirely overwhelmed. So I think that's a shift that sort of happened over time. We changed our pragmatic approach to how we view COVID and how it's changed our practice.
And just maybe a more background question. Were you actually, or are you currently seeing COVID patients, or you're in a different unit and still have to follow different measures now?
Absolutely. So I work in the emergency department. So I see COVID patients on a daily basis. And last shift I work, I know this because it was particularly, exceptional. I saw, I think 9 out of the 15 patients that I saw during my shift were COVID patients, 2 of which came in for a completely different issue. Or something that at least I thought was a completely different issue, and ended up testing positive during the day. So my exposure to COVID is continuous. My COVID risk is I'm caring for these patients on a daily basis, and critical care. So at the bedside, intubation if necessary, high flow oxygen, ventilation, the whole kit and caboodle.
And so I don't know if I guess you started working pretty recently in the hospitals, but you do read news reports from back almost every year. You kind of see hospitals are overwhelmed, people are being treated in hallways and bathrooms. Quebec has a big problem with hospital management and things like that. So do you know if there's actually a market difference in the degree of overwhelming, the state of overwhelmment, if I can make up that word?
Yeah. No, I understand the question, definitely. And I think that's a legitimate question coming from someone who's outside of the hospitals, because the recurrent message that's conveyed by the whistleblowers or the administrators in hospitals is that we're overwhelmed. And this is not a new problem. This is a yearly problem. It's been going around for 20 or 30 years in Quebec. This is nothing new, right? When I was a kid, I remember hearing news reports about, emerge rooms being full and don't come to the emerge if you have a minor symptom and whatnot. I think that's rooted in a bigger problem that I don't think I want to get into today, because it's more of a cultural difference in Quebec. We are drawn to emergency departments. We don't have as easy access to primary care physicians as in other areas. And coming from someone who's worked in Ottawa and who's worked in Quebec, I can say that the relationship that people have with their primary care physician is significantly different in Ontario than it is in Quebec. And just the proximity that Ottawa has to Quebec, I can see the difference in reasons why people came to the Emerge. So people that would come to the Emerge in Ottawa that were from Gatineau, for instance, typically came for reasons that were a little bit more minor because of the fact that they don't have access to their primary care physician in Quebec. So that's a long-standing problem that I think has many reasons. But you're right, the system has always been overwhelmed. And this is nothing new. And it always gets more overwhelmed in the wintertime because, well, people that have lung issues get sicker and they need to be hospitalized. And, viruses are more common in the winter and they're typically seasonal. The difference with COVID, and to answer your question, directly, yes, the answer is yes. There is a difference in the way our resources are overwhelmed. And the reason for that is, firstly, COVID is a more severe disease. All right. So COVID is not comparable at all to influenza. You cannot call COVID a common cold. Can
you just, sorry, before you go, can you just quantify that for us?
What do you mean quantify?
So when you say it's more severe, what does that mean? Like, does that mean it's, for like, let's say me, I'm 30 years old. What does that mean for me in my day-to-day life?
Okay. So if you say you're 30 years old, that's not necessarily something that's going to affect you directly because you're a young, healthy patient. And that's fine. Okay. But if you just look at numbers, let's just look at death numbers, for instance. All right. Typically, when we do our statistics in Canada, we'll include deaths caused by influenza and pneumonia together. All right. That's just a statistical thing that we do. I think most countries will do that as well. So if you look in 2019, total deaths, I think, related to influenza and pneumonia were approximately about 7,000 deaths in Canada. All right. So that's influenza and pneumonia. And I can tell you that deaths from pneumonia and septic shock related to pneumonia are probably more common than deaths related to viral pneumonia, such as influenza. So this is vastly overestimating the amount of deaths allocated to influenza. But let's say we go worst case scenario, give influenza its best shot against COVID. In Canada, we had 15,000 deaths last year related to COVID. And this is within 28 days of diagnosis. So typically, patients can die from COVID much after 28 days after their initial test. So this can actually underestimate the amount of deaths that were caused by COVID. And the same thing in 2021, 15,000 deaths. And this is not only a Canadian issue. If you go to the UK, you're looking at about 1,500 influenza allocated deaths in 2019. And they're at 40,000 in 2020 and approximately 98,000 in 2021. 98,000 deaths. That's 98 times the amount of deaths allocated to influenza. So, and I agree that there's a whole abundance of questioning as to, what do we consider a death that's caused by COVID? How many of these patients are dying from COVID, or how many of these patients are dying from respiratory failure, from heart failure, and just so happen to have caught COVID in the hospital? I think that those are fair questionings. I think that you can definitely question that. The only thing is the numbers are so abundantly clear. I doubt that would have a significant effect on the difference. If you look at studies that specifically looked at mortality related to COVID in Canada versus influenza, you're looking at 6 times approximately. And if you look at sites like Johns Hopkins, they'll actually report up to 10 times higher mortality rate as opposed to influenza. And these are not like itty bitty websites. These are like Johns Hopkins Medicine. They're big websites that were heavily involved in COVID statistics across the United States. So, and this is just mortality.
I guess maybe the question is, so if you told me, say, are you scared of getting 10 flus back to back of dying?
Mm-hmm.
And so would I be scared of getting 10 flus or 6 flus or whatever the factor is? Let's say you told me, Perry, you're going to get 6 flus back to back. Are you scared of dying? I would say no.
Well, no, but your numbers don't work though, Perry, because your risk of dying, for instance, to COVID would be approximately, let's say at your age, fairly low, right? You'd have to have a so you'd have to get 100, 1,000 flus.
Oh, sorry. So I was using this worst case scenario, which was 6 times, or right? What are you saying? I'm 100 times more likely to die from COVID, or 6 times more likely to die from COVID?
You're 6 times more likely to die from COVID, but your chance of dying is fairly low.
Right. So then the question is, me personally, should I be scared of COVID?
Should you personally be scared of COVID?
Yeah.
I think you should be more scared of COVID than the flu.
Right. Maybe 6 times more.
Sure.
But if I'm zero scared of the
that's
flu,
related. We're only talking about death. I don't expect you to die from the flu. I don't expect you to die from COVID.
Right.
Just in general.
Okay.
However, would I be concerned of getting the flu because would I be more concerned of getting COVID because I don't know, I can get a PE or a pulmonary embolism, which is a more significant complication of COVID, which is more frequent, or would I be more concerned of having long COVID syndrome, which are people that have shortness of breath and dyspnea while doing physical exertion for over 6 or 7 months? These are much more common complications of COVID that we've seen in young patients that suffer from these things for long periods of time. So I would say your risk of getting that is significantly higher than your risk of getting, I don't know, encephalitis, for instance, from the influenza.
So actually, on that note, I don't know if this is something that gets controlled for a lot in these studies. I haven't read many in depth, but in the past, were people getting tested very frequently for influenza, for example? So
No.
So then, like, if everybody in the hospital is getting tested for COVID, you're going to expect some elevation in the mortality, and you're going to study more of the bad side effects of COVID afterwards and things like that. So maybe, could there be an overstudying as well?
Maybe, but from a statistical point of view, this actually runs in favor of influenza, because we say that there is a mortality rate. For instance, we have 1,500 deaths in, let's keep the numbers simple, all right? These are not real numbers. These are just simple numbers to illustrate my point. If we have 1,500 deaths in 10,000 confirmed influenza cases, all right, that's 15% mortality. It's significant, right? Very extremely high. We don't test a lot for influenza because people that have influenza just don't go to the hospital. They stay home. They say they have a flu, they have a cold, whatever. So the number of influenza cases are vastly underestimated, vastly underestimated. So our percentage of mortality is actually exaggerated for influenza, whereas for COVID, we're under exaggerating it, right? So we're testing everyone, even if you have minimal symptoms, contacts, close, well, not the case anymore, but back then, close contacts. We're testing so many people, everybody that comes into the hospital for COVID, we know all of the COVID cases, right? Or we're closer to knowing the actual number of COVID cases in Quebec than we are of knowing the actual number of influenza cases. So we're actually giving you a smarter number or a more solid number for COVID mortality than we are for influenza mortality, which would make that difference even higher. So we're probably even underestimating our ratio with respect to these two things. But I want to get back though to the point, because I think your question was very good, and I think it would be very informative for people that are actually listening. Because we spoke about, are the hospitals actually fuller than they were? Well, they are, and the difference is treating for a COVID patient is very different than treating for an influenza patient. The isolation that's necessary, the amount of resources that are necessary, are extremely different. So it's much more resource hungry to treat for a COVID patient than it is to treat for an influenza patient. And the direct effect of this is something that we've never seen in all of, even if you look at our worst influenza cases, our H1N1 flus from 2010, I think it was, all the big flus that we've had, we've never had to stop operating people. I've never had to take a nurse from the OR and bring her to work in my ED. We've never had to do this. And this is something that is very, very typical of COVID. So from the perspective of someone who's at home, and I totally understand Perry's question, should I be concerned about COVID? No, I think if you're a 30-year-old and you're healthy, you have no, risk factors, you're not an obese. Well, mind you, your risk factor is that you're a male. That's your number one risk factor for COVID right now at the moment. No. Or you should be afraid of dying of COVID? No. Should you be afraid of someone in your surroundings dying? Maybe. I'd be more concerned than influenza. But these are not questions that we should be asking ourselves. It's interesting because I guess you guys are going to go into the moral aspect of it, but it's a very egocentrical way of thinking of things, of a very social problem, right? A generalized problem.
So actually,
yes.
Oh, sorry. I'll you finish up.
No, go ahead.
Do you have like a rough idea of what's the normal largest number of hospitalizations in a day in Quebec, for example? Like, what's the number of patients that can go to a hospital in Quebec in one day, right, in 2015 or whatever, a peak flu season, roughly?
Right. So I spoke to Perry about this. He mentioned it, and I wasn't able to find the number exactly.
Yeah, me neither. I mean, so they show like I was looking at the
Yeah.
Gazette, they show the number of hospitalizations every day since COVID, right? And there's these big spikes go roughly to the
Right.
mid 1000s in, I don't know if it's in one day, but maybe in a few days or a week. And I tried to go back and find data that shows me, well, look, this kind of spike has never happened before. And I searched through a bunch of databases from Quebec. Couldn't find anything. All I could find was number of hospitalizations per year, which looks flat. But I mean, there's no significant change in over 1 year. But I can still see a problem of like, well, it doesn't matter if it's over 1 year. We care that over a few days we have 1,000 people showing up, right? I don't know if you've read anything along those directions that could help me out here.
No, but I can actually mention though that I don't think that's an accurate number to assess really what we're looking to assess, which is how heavy the strain is on the system. So
yeah, I agree.
Again, if you have a significant amount of COVID patients, if you have 15 COVID patients versus I'll take 30 influenza patients coming into my hospital any day over 15 COVID patients, right? Because we don't have that requirement, that hunger for resources that COVID has. So I think that's a much better indicator as to what's going on. Not necessarily the spike in hospital stays, but the spike in COVID hospital stays. And a lot of the mandates and a lot of the decisions that were made by the government are not guided by the amount of COVID, the absolute amount of COVID cases. They're guided by the amount of people that are going or are predicted to be going into the hospital, because that's what scares people. That's what scares our decision makers. Is not 15,000 COVID cases, whatever. To be honest, 15,000, I don't care. We have that in flu all the time. The question is, are these people coming into the hospital with COVID? And that's where it's going to bend and eventually break. So that's what's guiding all of these decisions.
Sorry, why don't we care if it's because of COVID? Why do we care if it's just with COVID?
Because it implies and it requires more resources. We need more help. These patients need more care. They need ICU beds. They need more ventilators. They need specific nurses, more equipment.
I understand if they're going to the hospital because of COVID, right? If they get a severe COVID reaction and they have to go in. But I'm saying, like, do we care if it's people with COVID? Like, someone, like, I think I mentioned this, someone breaks their leg, shows up with COVID. Yeah. Does that matter?
So it does matter. It does matter because, so it does matter. It may not matter to the person who has COVID and has no symptoms, because, for instance, a typical situation is a doubly vaccinated person comes in, breaks his leg, was exposed to COVID, has no symptoms, gets a dépistage coming into the hospital, right? He's screened coming into the hospital, has COVID, right? So it's not going to affect the patient's health necessarily. So he won't necessarily manifest symptoms, but you're going into an environment where you're surrounded by patients that are vulnerable. So I can't take this COVID positive patient that may be shedding, okay, and that even though he's asymptomatic, can give the disease. I can't put him in a room with 3 88-year-olds with broken hips on the ortho ward, right? Because those people are going to end up dying.
But I guess the question is, it seems that there's a lot of people with COVID in the hospitals. Those are the numbers we see all the time, right?
Right.
So in principle, you can put them in a room with other people with COVID.
Yes.
So
yes, but those rooms are more, that's more resources though. It's more difficult to use those rooms, right? They need more, it's different care, but you can, you're right. You can, but I don't think that these are the patients that are driving the concerns of the government. I think the vast majority, I think these are minimal cases. I think the vast majority of patients that have COVID are there for respiratory symptoms. And you can argue whether or not they have heart failure or whatever, but they're there for respiratory symptoms with a lung that looks like a COVID lung, right?
I guess that what I'm trying to get at is often when you hear when you see one of these press conferences, you see a graph with these lines going upwards,
right?
And this is used as justification for why we need some mandates,
right?
But in reality, these numbers are not as transparent as we'd like them to be, maybe, because what we want to know is specifically what we want to know is how many resources are being used up compared to how many we have available.
Mm-hmm. But we know that that's not going well. We know that because we're again, people are absent in the healthcare system, and we're cutting surgeries. So we know that we don't have enough to deal with it. Now we can argue as to whether or not why we don't have enough. Is it because we didn't fix the healthcare system when we should have 20 years ago? Maybe, but now we're in the situation we're in, But you're right. You're right. But I think it's minimal. I don't think that the amount of COVID, the surprise COVID patients that we get because with broken legs, I think those are minimal cases. I would say the extreme majority of patients that I test for COVID that come back positive are symptomatic.
Sorry, can you repeat that? The extreme.
I would say that the vast majority of patients that come out positive for COVID have a symptom of COVID and are at the hospital for a symptom of COVID. I think that the numbers, the patients that show up randomly, that come for other that are surprise patients that come for, let's say, rectal bleeding and have a positive COVID test, I think these are outlying numbers.
Okay, and you're also, I guess, are you also saying that these people couldn't stay home? They need hospital care.
Well, it depends on what they come to the hospital for. If they come for the hospital for severe rectal bleeding and they have COVID, I can't just send them home because they have COVID.
I guess what I'm asking you is, if I have a flu, I can go to the hospital and you can pump me with fluids and maybe the flu goes easier.
Yeah.
If I have COVID, I can also maybe stay home or go to the hospital and you pump me with fluids and things go easier for me.
No, but if I can pump you with fluids, you won't get and send you home, you won't get hospitalized. You'll be in the emerge, you'll be in passage of the emerge, but you won't go to the wards. You won't be hospitalized for COVID. So a hospitalization number per se is someone who goes up to the wards, right? Who's admitted. Okay. Not a 30-year-old who's, I have muscle pain, I can't deal, I'm tired, I can't drink, I have fluids and home. No, none of that.
I see.
We have a lot of that. I'm not gonna lie to you. There's a lot of that coming in. A lot of people take the ambulance because they have COVID and because COVID is a bad thing, but it's minimal.
So Carlos, I don't know if you have anything other specific to add. Maybe we can go into specific mandates.
Yeah, Perry, go for it.
Yeah. So thanks for that. I guess that introduction on maybe not an introduction, but an in-depth view of what's happening in the hospitals. But we wanted to ask you specifically about certain mandates that have passed in Quebec. And we don't know if maybe you can tell us what you think of these mandates and which ones you agree with, which ones you don't agree with, which ones you think are justified or justifiable. Mm-hmm. This can be anything from wearing masks, vaccination, vax passports, all this
curfews,
right. Gatherings, whatever.
The hospital, the hotel ban. This is not Quebec, but it's also Canada. I'm curious if you have any thoughts on that as well.
The hotel ban? Sorry,
not hotel ban. The hotel quarantining. I thought that was interesting. So, maybe we could do a sort of what's that? You look back, a retrospective, right? A timeline, right? Maybe how the story unfolded and what are your thoughts along the way and right. What lessons we've learned, maybe.
I think the first thing that we have to say is that the last time this happened was over 100 years ago, right? The last time we had a global pandemic like this, times are significantly different. Medicine was significantly different.
So what are you talking about? Like the Spanish flu?
The Spanish flu, for instance, like the last pandemic. Pandemics are typically about 100 years apart, right? Typically,
but wasn't the Spanish flu much more deadly?
Sorry?
Wasn't it much more deadly?
You can't really compare the two. How could you compare the Spanish flu in an era where there was no medical care, no adequate medical care? You can't say it's more deadly. If we got the Spanish flu today, there's no saying that it would be like a normal flu. You can't really compare the two. I can compare, for instance, you can say we can talk about smallpox or polio or things like that. We can definitely talk about that when we come to vaccination. But we can't compare. That's like saying Maurice Richard is a better hockey player than Wayne Gretzky was. Well, you can't really compare them because they're in different times, and probably they would both get their ass kicked by Sidney Crosby. So I mean, these are I don't think you can compare the two. But what I can say is we really didn't have much experience with the global pandemic. Like we had thinkers or medical specialists or preventative medicine specialists and people that thought and wrote and prepared for it, just like we prepare for disaster medicine, for earthquakes and for nukes and whatnot. We prepare for these things, but until you live them, you don't really know how you're going to react. And there's a lot of things that come into account with these things. There's politics and there's, decision makers and but one constant that's always been there is the doctors are free thinkers and they think for themselves and they believe in peer reviewing. All right. That's the first thing that I want to say. The other thing is when you look back at all this, I think a lot of the reactions are visceral. A lot of these decisions are visceral, and I'm not going to be ill faith and say that these decisions were made, to harm people or to dissatisfy people. I think a lot of the decisions that were made with the information that we had, the resources that we had, and in the goal of protecting people, and more specifically, the more vulnerable. Okay. I think, well, I'm not going to lie to you, shit hit the fan in March. A lot of people started dying very quickly. A lot of people got very concerned. And a lot of people were very critical on governments that didn't react fast enough, especially in Europe. Okay. And I know this because when, fire was hit, when shit hit the fan in Europe, I was in a ski line with over 300 people.
Sorry, Mas, but on that note, is it true that in Quebec, during the first wave, something like 80% of deaths were in nursing homes or something like that?
It's a crazy number like that. All right.
Okay.
And what I can say that is that Quebec, initially, we were one of the champions of COVID, right? So we were one of the worst hit areas in the world. We were next to areas like New York and Italy when it came to, per capita COVID deaths, per capita COVID cases. And we were also one of the governments that reacted the quickest. All right. So we were the quickest to come out and to do something. All right. Now, people are saying, well, why are you doing a curfew? There's no evidence on whether or not curfews work. Well, you're right, but we never really had a situation where we could test them. Right? You can't really ask for evidence-based medicine or evidence-based, public health if it's never happened. All right. And if you look at the graphs for when curfew started, I mean, the cases drop. Now, there are other measures that happen at the same time. Kids come out of schools and, vaccination has started happening, and there's a whole bunch of stuff that started happening. But the reality is, whether the correlation implies causation, it's still there. There is a correlation with the initial curfew and a drop in COVID cases. Can I argue with you or with anybody who states that there's no medical evidence that supports the use of a curfew? I can't argue that. It's not false. There is no evidence on that because we never really had the opportunity to test it.
But here's the question, though. I would argue maybe that placing a curfew is taking people's rights away. To some small or large extent, we can argue that, but there is some rights that are being taken from people by imposing a curfew. So if you're gonna, I feel personally say, if you're gonna remove some rights from the population, just to guess and hope something works, it's a bit misleading, and it's maybe not the best approach if you want to test this curfew system, right? You should have some logic behind why you're doing this if you're going to take someone's rights away. That's what I would argue from one perspective. Maybe
I would tell you that if you put a curfew, then you are removing people's rights. You're not taking certain rights away. You're removing their ability to freely move. All right. But this is not the first time we do this in medicine, though, right? We can put people on forms if they are a danger to themselves. We can hold them against their own will, right? Now, this is on a very smaller level, and it's not an insignificant act. It's a very significant act, both legally, morally, ethically, everything behind that.
But now it's population-wide, right? It's regardless of your status,
correct?
COVID status, or it's like you're born and you can't go outside, right? You're born in an illegal state if you're born outside, say.
Right. And so what you're arguing is this the main argument whenever people are against most of the mandates is this, right? Is the main value that guides bioethics is autonomy, right? Is person's ability to self-regulate or to self-rule, their ability to decide for themselves what they want their care to be and to do whatever they want to their body. Okay, now, unfortunately, except for abortion in some areas of the world, but the reality is that that's the main principle that guides medicine and how we practice medicine today is autonomy. So if Perry comes into the hospital and has appendicitis and he doesn't want to get surgery, well, if he understands what appendicitis is, if he understands what the treatment for appendicitis is, the risk and complications of not doing the treatments, if he refuses the treatments, then Perry is entitled to not get the treatment. All right. He's going to get peritonitis. My job as a doctor is to tell him, well, you're going to get peritonitis. You're going to go into septic shock and you may die. But if you tell me, Dr. Iseppon, I understand that, I don't want the surgery. I'm a grown man. He's been informed. He's not coerced. And he's making a decision for his own personal health. This is the principle of autonomy. It's the guiding principle in medical bioethics. It's not the only one, though. And that's why that's where things come in a bit differently when we talk about, especially, public health. Because then there are other principles and values of bioethics that come in, like non-maleficence, and it's the main reason why. And we've spoken about this before. If you want to drink and drive like an animal, it's your right to. You're free to do so. However, you doing that takes away someone else's right to drive safely and not drunk. So by putting someone else at risk, this kind of scrambles a bit of the principle of autonomy. And I think that, it's widely, when the consequences of your actions have impact on someone other than you. For instance, when you talk about the appendicitis, you're the only person living the consequences of your actions, which is widely accepted as being fine.
That's not necessarily true, right? Like, let's say Perry decides to die alone of appendicitis. Now his daughter doesn't have anyone to support him, right? And then she's going to become a burden on the system.
Well, that's true, correct. But
you can follow that logic further, right?
Right, you can follow it further, but it's from a medical standpoint, however, though.
By the way, knock on wood, Perry. That was really dark. Go on.
It's only appendicitis. Worst comes to worst, we can treat him. But what I mean is when your decisions have significant impacts on the health and the security of others, then that kind of scrambles the idea of autonomy. And I think it's widely accepted. I think that limiting other people's freedoms when it's necessary to prevent harm to others is typically something that's widely accepted as being ethical. And this is not something that comes from the fruit of my reflection on it, because I don't really sit in bed thinking of these things, but there are a lot of groups that have sat down and thought about this. And there is a group, I forget what it's called, but I think it's it's an association of bioethical program directors that have had, numerous position statements on this, saying that we accept mandates as being, from a bioethics standpoint, justifiable for the greater good and for the health of people around them. Because the other aspect that you could look at is, what if you can get vaccinated? Okay, the possibility of you not being able to get vaccinated is minute. You need a severe allergic reaction, or if you have a significant condition that prevents you from being vaccinated, fine. Well, letting people go unvaccinated puts the people that can't choose to be vaccinated at risk as well. Mind you, these are minimal portions of the population. But I understand why we're going towards that from a public health standpoint. Autonomy has a very strong pull, but it's not the only principle that comes into play.
I think there's maybe sorry, Perry, just to finish that up. Maybe we can, again, this is just, I'm not a bioethicist either, but just from seeing this actually affect people's lives, I start to think about it a bit. But we can maybe distinguish between like proximal harms and, societal harms. Like we kind of brushed on that, right? Like you told Perry, he shouldn't be worried about getting COVID because chances are he won't even notice that he had it, right? So, if I give COVID to Perry, he shouldn't be worried. Most people shouldn't be worried about catching it just by going out, right?
I wouldn't say most people. I wouldn't say most people. I would say a lot of people. 90-something%,
whatever. Let's say a big chunk of people aren't going to.
There's a lot of old people. There's a lot of elderly people that.
Granted,
there, so anybody under the age of, I would say anybody under the age of 45.
Okay, sure. Yeah, I can give that. So then there's the danger that is like somebody's going to give you COVID on the street and that's going to harm you, right? And then there's the danger that you also alluded to, which is, well, the hospitals are going to overflow, right? And I think that's a different kind of conceptual like burden on society that you're creating, right? I don't know if that's something that's like we shouldn't consider it, or it's going into some sort of uncharted territory that we don't know how to deal with.
I think we should consider it. I think I am not going to be a hypocrite and say that I'm not heavily biased by my personal experience towards vaccinations and the support of mandates. I'm not going to sit here and bullshit you guys and say that I'm not. I am. And I think that that's the reason why we're having discussions with opposing viewpoints, right? My experiences are those that come from and then we can argue whose experiences are more valuable. But the reality is that, your personal experiences are those that are most valuable to you. So I think that you're right that there are proximal and distal effects to this, but I think that we're talking about a societal problem that can't be looked at from an individual perspective, and that's that's the whole science behind public health. It's not personal and public health; it's public health. Is what do we do for the greater good of the population? And again, it's why everyone needs to wear a seatbelt, why we should be wearing helmets when we ride our bike, but we don't, and that's another discussion that we can have. And why you can't yell fire in a movie theater, because these are things that you can't do. You can't create chaos from a public health standpoint, and it's a guiding principle. The only way to, and I don't know if I'm moving away from the question, but the only way for us to beat this is to get herd immunity. And there's a common misunderstanding amongst people that are against vaccination as to what causes and what is herd immunity. So herd immunity is not something that we can get by all getting the virus. And I think we're proving this right now, okay? There's a buttload of people getting the virus right now, and all that's happening is it's mutating. And the reason why it's mutating is because there's still a significant chunk of people that are not vaccinated and that aren't immune to it. So and people are going to say, well, why are we getting third and fourth and fifth doses? Because we're not running together. We're all running different races, right? I mean, I think that by the time we get herd immunity, Israel is probably going to be at dose number 10. We may be at dose number 8, but at least Africa will be at dose number 2. And that's the reason there's the disconnect between where we are and where we should be. And vaccination is, and mask mandates and social distancing, they're all great to mitigate risk immediately, but long-term, it's not feasible. I mean, these things are creating harm for everyone, economic harm, psychosocial harm. My wife's a psychiatrist. She can talk to you hours and hours and hours on end how people are getting worse with their main psychiatric conditions. They're getting more depressed. Things aren't getting, people aren't getting better from a psychosocial standpoint. So these aren't long-term feasible solutions. The only feasible solution long-term is an adequate, diffuse, worldwide vaccination process. The same we had for polio, the same we had for tetanus, the same we had for smallpox. These diseases are no longer present.
So I don't know if this is going to open a rabbit hole that we may not want to get into, but I'm just curious what you think. So once you catch COVID, you have natural immunity to some extent. And there are studies that show that it's stronger than the vaccine, right? So would it be the case that if everybody got COVID at the same time, just like if everybody got vaccinated at the same time, this is obviously a weird imaginary situation, it would still sort of work, right? In theory, and maybe even better because the natural immunity would probably protect you further than a vaccine could, right?
But the problem with that is that that's what's happening right now. And, basic principles of virology tell you that a virus only wants to survive, right? And what it does to survive is it mutates. So by catching the virus and living it, as hosts, we're promoting it to replicate and to mutate. Whereas by giving vaccines, it's completely different, right? We're just developing immunity. So we're running after, there's a new variant today that just came out from France. I forget the name of it, but it may be a variant of concern in 2 weeks. Who knows? So I think that, and that's the result of everyone getting COVID. But theoretically, from a theoretical standpoint, if everybody got COVID at the exact same time, probably be more better off than if we got it over 2 years.
But I guess the people that are vaccinated have been shown to have viral load, right? The virus can still replicate in vaccinated people. Granted that there's some amount of variation in the virus.
Significantly lower than someone who's non-vaccinated.
Okay.
Much less likely to transmit disease.
Okay. I remember seeing some studies about viral load comparison between vaccinated and unvaccinated. Maybe I think that's because Delta came in and that one was bypassing vaccines quite a bit more than Alpha. Does that make sense?
Well, actually, Delta was not so bad. So if you look at the numbers, grosso modo, all right. So alpha, beta, and initial variant, right? Initial disease that stemmed from Wuhan. You're looking at about 95% efficacy of the vaccine, 90 to 95% efficacy of the vaccines. We can talk about vaccine and the purity of the data. I'm happy to discuss that. But that and a significant, like over 95% protection against severe disease. Delta, I think those numbers dropped to about 80 about for prevention of symptomatic disease, but still over 90% for severe disease. Right now, with a single dose, you're looking at 30% for Omicron, 30% prevention from symptomatic disease, approximately 70% prevention of severe disease. Both of those numbers go up to 70 and over 80% with a third dose. Okay. Those are the actual numbers that we have right now. So Delta wasn't as resistant to the vaccine. We only really started seeing reinfections with Omicron.
Yeah, so I guess everybody's confused, right? Because Quebec has such a high vaccination percentage and still a very large number of COVID cases, right? Modulo increasing in testing or whatever. Is this the vaccine being bypassed by the virus now?
Yeah, so it is. Well, you're right. And the problem with that is that and I'm trying to put myself in someone who's who got vaccinated and maybe may regret being vaccinated by being faced with these numbers now. So people who are against vaccination will say, well, look, we're vaccinated. We're one of the highest vaccinated states in the world, and we're still getting slammed by COVID. Like, what's the deal? But this isn't a testament to vaccines not functioning. It's a testament actually to the disease being widespread and mutating. This is normal basic virology. What I have to say though, I totally understand someone being like, well, not being in the field and being like, well, we did what you told us to do. We got vaccinated. We did the effort, and now we're still getting sick. And some of these people got COVID once, got vaccinated twice, and getting COVID the second time. It's extremely frustrating from a population point of view, especially when they come back and hit us with more restrictions, more things that, we did our effort. We did what we could. We did everything we were supposed to. And now you're slamming us back into confinement. This is extremely frustrating. People have to understand that, unfortunately, we're making these decisions not because of the number of cases, but because we're concerned that if you have a heart attack and you come to the hospital, that I won't be there to treat you and you won't have a bed. Because right now we're transferring patients left and right in the hospitals. We're delaying care, and we're not giving optimal care for diseases and conditions that we used to treat normally and well before. And this is because of COVID. And unfortunately, I can't close my eyes and not treat the COVID patients and just treat the heart attacks like I normally would. I need to treat both. But I'm a human. I'm a social being. I have a pregnant wife. That I sent away for the holidays. Thank you. That I sent away for the holidays, because I didn't want her to get COVID. I'm affected by this from a social standpoint just as much as anyone else. I mean, and if not more, because I'm constantly exposed. I'm constantly concerned about getting my mom sick, my brother sick, my sister sick, my pregnant wife sick. So I understand these people that are frustrated and irritated by this, and that say, there's nothing that supports. Why are we so back and forth? What is guiding us in making these seemingly random decisions? And I think this opens a doorway for me to say that, and I think you'll probably be surprised to hear this. I think the government, and this is from Quebec standpoint, I think that a lot of the things are justified. I think the way they went about it was not ideal. I think a lot of decisions that were made were partisan. I think a lot of the decisions were delayed. I think we didn't utilize information that we had the opportunity and the chance to have early information from Europe 5 weeks in advance that told us we were going to be hit again the same way we did. We didn't vaccinate more for third dose. We weren't preemptive. And now I think we're stuck with these extra measures because of our inaction. And the main thing that I think vaccination hesitancy is largely related to trust in government. If you look at a lot of places, if you look at Hong Kong and India and a lot of Russia, a lot of these places have a lot of vaccine hesitancy, and a lot of this is related to the fact that they have hesitancy and questioning towards authority. And this is a normal thing, right? If you look at Hong Kong, I mean, I'm not surprised at all that people question vaccines because the government is telling them to take the vaccine and they don't trust the government.
And by the way, on that note, I just read a study that showed that people with PhDs are the most likely to be vaccine hesitant.
Of course,
I guess
because they're the most likely, but they're the most likely to question, right? All right, and that's fine, but that's fine. But I think that if they're PhDs, they should have the ability to review the data adequately and to see that vaccination is safe and efficacious. But a lot of this is related to government trust. Initially, when we came in, we were unprepared for COVID. We had no, we had no masks. We had nothing. And the government told us not to wear masks. So they didn't make a difference. And then they told us to wear masks. So the government has been flip-flopping back and forth with a lot of the mandates. And this creates hesitation and distrust in the population. And unfortunately, a lot of the organizations, like l'INSPQ and l'INES and all of these government, these organizations that are filled with competent, doctors that are absolutely credible and that have a lot of scientific integrity that make these recommendations. Unfortunately, all of these organizations are government based, so it's hard to know what's what. I don't want to get my medical advice from François Legault. I mean, I don't want that. I'd like to think that the guy behind him, who's my public health expert, is telling him what to do, and he's just conveying that. I like to hope that a lot of my public health decisions aren't stymied or affected by, political reasons or partisan reasons. I'd like to hope that. I don't have that certainty right now. I can see people being concerned or hesitant from that point. But I mean, vaccine hesitancy is nothing new, by the way. I mean, this is something that's been around for 200 years. It's something that was, when we had mandates for the polio vaccine 200 years or in 18 some odd, there were riots, in Quebec. And I mean, in retrospect, I mean, it was great. But polio was a much not polio, sorry, smallpox. My bad. Smallpox was a visible disease. You were disfigured. You didn't want to get smallpox. It's not like COVID. If you get COVID, you might not notice. Nobody might notice. But if you get smallpox, you're disfigured, and you can tell. People stay away from people that have smallpox because you can see they have smallpox, right? So there are different, motivations that are driving people. I don't know if I'm being clear. I'm sorry. I'm giving long-winded answers.
No, it's all good. But so I have a question. So do you think hospitalizations would increase dramatically if we said everybody under 45, like you said, that shouldn't maybe necessarily care that for their personal health about COVID from a COVID perspective? So if we said everyone under 45, there's no mandates, and everyone over 45, we force them to stay home and curfew and all this stuff. Of course. Why would things increase?
Well, if you're under 45 and you have no mandates, if everybody under 45 gets COVID, you think everybody under 45 is going to avoid their parents? They're going to avoid their grandparents? They're going to avoid they're going to be in contact with these people anyways.
I mean, yeah, but we can make the same argument for right now when everyone has to be forced to stay home. I'm just saying, given that everyone respects the rules, what would things change dramatically?
Well, people aren't forced to stay home right now. I think that
after 10,
to be fair, the curfew, I have nothing to give you to support the curfew at the moment, other than the dip in cases during the initial curfew. I have no reason to understand or to think that keeping people inside from 10 to 5 is going to make much of a difference. You're better off just closing the bars. It's the same effect. I see no benefit in adding a curfew. I think it's a dumb measure that is just added for no reasons. They're flip-flopping with the dogs that can walk. I don't see that benefit. But
so let's say gatherings at home, right? If I get a bunch of 30-year-olds to gather at home, I allow that. Would that increase dramatically the hospitalizations?
Yes. Yes, it would increase the amount of cases dramatically. These people are going to be out and about. They're going to be interacting with people that are over 60, that are over 65. They're going to be interacting with them in stores and restaurants. They're going to be, they'll be, yes, it would. I mean, we're social beings, right? We still intertwine with each other. You can't just restrict the under 30s because they want to go out and party.
I guess so. So here, maybe this is a better question. If we added mandates just for stricter mandates, say for people above 45, but put no mandates for people under 45. I guess what I'm getting at, is there a way to add mandates for the at risk, such that the people that are not at risk could have a semblance of a normal life?
So I'm a little confused because you were the one asking me the question regarding autonomy and restricting rights and stuff. So what I understand is that a young guy is asking me, can I not have restrictions and restrict the autonomy of someone that's older because they have risks? No, but I guess this is what we do in general, right? We say, like, if you don't want to die from bungee jumping, don't go bungee jumping. Or if you don't want to, if everyone has the flu and you want to avoid the flu, don't go. Not at all, because I can't. The example would be, if you don't want to drive, if you don't want to die from a car accident, then don't drive. Or if you don't want to die from someone who's a drunk driver, then don't cross the street. But the reality is, you're putting these people in situations where they have no control. And so that, I guess, if I don't want to die from bungee jumping, don't bungee jump. I cannot bungee jump. But if I don't want to die from COVID, I can't avoid everybody that has COVID all the time because I won't know they have COVID. I can stay home infinitely, but that's restricting rights for the more vulnerable for the sake of the least vulnerable, which is the opposite of what we want to do. We want to keep.
Okay. What I would argue maybe is we want to avoid risks for the young people, and maybe let the old people take more of a risk, or just a natural risk because they're older.
So why doesn't everybody take a minimal risk and get vaccinated?
Okay, well, there's other things involved here, right? Because the vaccine is not, there are risks to the vaccine, of course, like every other medication.
Minimal, and they're quantifiably minimal. They're under 1%.
Sorry, maybe Carlos can pull up one of these. I don't know what the number is. We looked at this earlier.
I mean, there are the ratio of risk to safety for the vaccine is different for young people versus for old people, right? I mean,
right.
Just because they're
younger people under the age of under the age of 30, you have a higher risk of you have a risk of developing myocarditis. One case in 10,000 people.
Well, what's the case of something bad happening from COVID for under 30?
Sorry?
What's the risk of something bad happening from COVID for people under 30?
It's probably lower than that. But again, like I said, what we're doing is, the vaccine is not only something to protect you, it's to protect others and to allow us to get back to what we were doing normally, to see your parents.
I guess so here's the question, right? So we're maybe just to summarize or see if I understand correctly. You're saying that we're adding certain risk to young people. Mm-hmm. So we're making things riskier for them by giving them the vaccine, just so older people can benefit from being able to have their rights back eventually.
Well, not older people, everyone.
No, but I guess what I'm saying is, if everyone under 30 took the vaccine, you're increasing the risk, say, by some small percentage.
Yes, minimal.
Okay, but there's still a higher risk. So we're asking
there's a theoretical risk, yes.
Well, yeah, it's an experimental risk. Like, there's a risk involved. Right?
Yeah, sure.
So we're adding, the younger people are taking on more risk than they would have by not taking the vaccine, say, just because we want older people to benefit from this lower risk.
Because from a societal standpoint, the risk that the young people have from getting the vaccine is significantly lower than the older people would have from being exposed to COVID.
Okay, that's fine. But I mean, at one point, I guess, okay, so what I'm getting at here right now is, Carlos, go ahead.
I mean, I think I can jump in here.
I've been speaking for a while.
I think maybe in terms of bioethics, could you say that there's also a guiding principle where individuals can choose what degree of risk they want to take on, right? If a 15-year-old boy thinks 1 in 10,000 is too much for him, should he be allowed to make that choice, right?
Yeah, so that's a good point. There's an article by Michael Kowalik, he's a
I read that. It's a great article.
Yeah,
I mean, I don't know if it's exactly the same one.
No, it's an interesting article, but he's if you read all of his other stuff, you can tell that you can tell what he's arguing. And he will argue that it's unethical for us to ask someone to take a risk for the greater good of others. All right. And this is an article that typically, so it's something that he wrote in 2020. but it's something that I think has been said in the past before, because it's a conjuncture that we study in school as well. And again, and I think he is right. I don't think he is wrong. The issue is that he is right from a personal perspective, but he is wrong from a public health and a societal perspective, because we can't function like that as a society. If we all do that, then we will not function. All right. And I think it's strictly theoretical and strictly philosophical, but he's not wrong. He's not wrong. I understand his statement. His statement is that we should not, I shouldn't have to take on risk, however small it is, so that you don't die. And that's fine. But I think it's when he's going to be 65 or he's going to be 70, don't expect other people to save your ass at that point too. And that's strictly egotistical.
But I think right now it's a force, like we're almost coercing or forcing people to take, like to put their kids in a situation where they have to take more risks, right? So when we start vaccinating kids that are 5 years old up to, or what, I don't know, the 12 years old, I can't remember what it is, but we're asking parents, without even divulging, I think, properly, that they're putting their kids at higher risk from the vaccine than from the COVID.
Okay, so since Omicron, the ICUs have been filling up in pediatric hospitals as well. And in all likelihood, the risk of being hospitalized with COVID, or the risks of the vaccine versus being hospitalized from COVID are probably very, very similar. All right. They're even in pediatric populations, they're probably, and I would probably argue that your risk of seeing a complication from COVID are probably very, 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 very similar to your risks of getting a complication from the vaccine. I mean, when
that's kind of weird, right? I mean, isn't it weird?
Sorry?
Isn't that weird? Like, to give someone a vaccine that has a similar amount of risk from the disease that it's protecting you from?
Well, okay, I see what you
mean. I understand, like, so then
I see what you mean. Yeah, no, I see what you mean. I mean, again, I'm spitting numbers out, but what I mean is they're probably both low. Okay. The only problem is that the risk from the vaccine, okay, even let's say you do develop myocarditis, the odds of you getting better from the complication of the vaccine are significantly better than the odds of you getting better from the complications of COVID. Like if you're the unlucky one that gets a bad case of COVID in your 30s, I mean, you can die. I'm not being like crazy. There are 15 people a day between the age of 30 to 39 that are being hospitalized every day in Quebec now. These are not like low numbers like we used to have before. There's 15 people a day. That's only, and if you look at the numbers, surprisingly, the numbers dip between 40 and 50 because they're a heavily vaccinated portion of the population. They're similar, hospitalization numbers are similar 30 to 39 and 20 to 29 than they are for 50 to 60. And that's saying a lot. That's because these people, this is a portion of the population that isn't vaccinated. You spoke about coercion. I agree. Okay. If you take my statement from before, and my statement is completely different than that one of that of Kowalik, I will take the one that Kowalik mentioned, and I will argue the complete opposite. I will say that mandates and forced vaccination is justifiable for the greater good. Okay, so the minimal risk taken on by a person to get vaccinated is justifiable for to limit the harm, the significant harm and widespread harm that would be caused by COVID and whatnot. Whenever you have to do mandates or you have to coerce people to get vaccinated, obviously the best way to do so is the least coercive way possible, right? So what we don't want is to do like some countries are slowly but surely going towards now, where you need to get vaccinated. That's it. You need to get vaccinated, or you get a fine, go to jail, whatever you want, gun to your head if you're in Russia, whatever. What I mean is we don't want to do that. The idea is to use the least coercive ways possible. So initially, what do we do? Well, we say, listen, vaccination is safe, vaccination is effective. You want to get back, they show a bunch of commercials with the little kids hugging their grandparents. This is what we need. Or the little kids going like this, vaccination, screw you, COVID. This is what we're doing, right? So we're teaching people. But we've gotten to the point, like every vaccination campaign in the world of all time, we're here, right? We're here. All right, we're on a flat surface right now. The people that aren't vaccinated are not going to be vaccinated. They have done their research, or they think they have. They are convinced that vaccination for them is not okay. And I want to be clear, COVID vaccination. Because if you look at the numbers, there are significantly more people that are against COVID vaccination than there are that are against vaccination in general. Being COVID vaccine hesitant doesn't mean you're anti-vaxxer. You're not. I mean, Jenny McCarthy yelling on the rooftops saying that you shouldn't vaccinate their kids because they're not going to be able to put 3 blocks together, right? This isn't the case, right? This is not what we're talking about.
But could it just be because the risk from COVID for younger people is already so low that the logic is, why would I add more risk just to prevent a 95-year-old from dying from COVID for my kids? Say, why would my kids
not necessarily a 95-year-old? It could be the parents.
It could also be that if the hospitals are overwhelmed, it harms everyone. You could even
exactly
say that, like even the kid with a broken leg won't get treatment. I mean, I
absolutely.
But I think maybe where people get hesitant, not necessarily about vaccines, but is that, are we going into are we moving in a direction that's potentially dangerous, right? Where we say, all right, now there's a therapy that doesn't necessarily benefit you directly, but is of some general social good that the government decides. And you sort of become a servant in a way of the greater good, right? I mean, this can maybe in isolation be okay, maybe in temporary measures, but you can see it playing out, its course in places like China, for example, right, with the social credit system and things like that. So I'm not saying it's going to get there, but we do get used to these kinds of ideas, and it is kind of a new step that we've gone towards, right? So I think I just want to finish with like something like, well, we have to think about what's the way out, right? Like, how does it end so that we don't keep going in that direction? But anyway, thoughts on that?
No, I think you're touching on a good point, because you're touching on a point that is inherent to us as democratic and societal beings that live in a society with a government and democracy. Elected officials that make decisions for us. It's not the best way of doing things, but it's definitely it's not a perfect way of doing things, sorry, but it's probably the best way that we have available to us at the moment, right? And they're making decisions for us. And it's very difficult for people to just baseline submit themselves to that, even more so when we're talking about their health. And I think giving up liberties to the government has always been an issue, and more so nowadays in the different culture that we live in with social media and our general awareness to these inequities and these situations. I think it's a normal feeling to have. But just so we can be clear on numbers, if you take everybody all together, all right, and these are numbers for Delta, because I don't have numbers for Omicron, because Omicron is still being studied. But if you take everybody together, all tout âge confondu, so young, medium, adolescents, young adults, and older people, your risk of being hospitalized is 5 times higher if you're vaccinated, if you're unvaccinated. Your risk of dying is 3 times higher. And these are 95% confidence intervals, valid numbers, vaccinated, non-vaccinated, incarnated, with adjusted odds ratios that fit. Okay, so I am going to disagree with you're doing something to only benefit others. The data is overwhelmingly clear that you're benefiting yourself. You're putting yourself at a high. Now, I'm not saying that these numbers are the same across all age groups, but they're probably higher. You're probably looking at a 6 or 7 or 8 or 9 time chances if you're over 80, and just a 2 time chance if you're between 30 and 40. But the numbers are overwhelmingly clear. And these are numbers that are available on StatCan. And I'm not going to get into whether or not we can trust StatCan, because or else we're going to just argue into a corner. But these are numbers that we have available across all age groups. So these are not something that you're doing for everyone around you. It's something that you're doing for yourself as well.
Yeah, so I think we can accept these. I guess what I'm trying to say is I don't think we believe in some conspiracy of.
Oh, no, I don't think that either. I mean, you're scientists.
No, but I guess we're also concerned about, I think what Carlos touched upon. Are we heading towards a direction where right now we're forced, we've set up a situation where we almost force people to take a chemical that or vaccine, whatever, something that does not.
Words are important.
It's a chemical, right?
Okay, well,
everything is.
Everything is a chemical.
A treatment.
A treatment, sure. That at least for young people does not significantly change the odds of them something bad happening to them in COVID.
Nobody does though. That's what I just said. It does.
Well, I mean, 3 times could be 0 times 3 is still 0, right? You have a 0% chance of dying from COVID, and 3 times.
Right. Okay. So you can argue relative versus absolute numbers. That's fine.
That's
fine. The risk is low. The risk is low. The risk is low. Fine.
I guess what we're trying to say now is, well, now what happens if tomorrow the government comes up with a new policy, like everyone has to do X, Y, Z? It doesn't open a door for the next issue or the next.
Yeah, I think I don't know if I was clear, but I agree with that. I agree with that hesitancy. I'm okay with that. But let me ask you this, Perry: how many people that refuse to get vaccinated? All right, out of all the people that refuse to get vaccinated, how many of them have been forced to be vaccinated by the government?
What do you mean? Like,
how many people that don't want to get vaccinated were forced to get vaccinated?
Some, I don't know.
Zero?
No. I mean, it's more than zero.
You have to define, I guess.
Well, who was forced? I mean, no one was forced, right? People make decisions. So if I don't want to lose my job, then I'm going to get vaccinated. All right. If I want to, pretty soon, if I want to go to the SAC and if I want to go get my weed, well, I need to get vaccinated. Or if I want to go to the restaurant,
you have to define force, right? Like you could say,
right,
if you don't want to get vaccinated, I'll shoot you. I mean, you don't have to, but I'll shoot you.
Well, that would be forced, though. That would be forced.
Okay. It's still a choice, right?
Yeah.
You're still
You can be coerced. People are being pushed towards. They're being coerced, but they're not being forced.
Okay, so what's the difference between force and coercion? Actually, that's an interesting point.
Because you're still making your own decision. In the sense that, like, you're deciding. For me, what's important is I want to go to the restaurant now. So the restaurant is more important for me than vaccination. Then that's good enough. See, but you're still making the decision.
But in the limit, with a gun to your head, you're still making the decision. My life is more important than getting vaccinated, right?
There's sure. Yeah, you're right.
It's always a choice. It's always a choice.
That's a good point. That's a touche.
So I mean, there's always a choice. I guess. I think maybe you agree with us that we're giving up some liberties, right? The government is so everyone is safer maybe with a vaccine, but what it's costing is liberty to some extent. Some small maybe extent for you, maybe to larger for me, maybe even larger for Carlos. But we are paying for this. We are paying for this somehow.
Yes, that is the cost of us getting out of this. Is to a certain extent our liberty. I can't disagree with that. Okay, I can't disagree with that.
And I guess then the rest of the arguments is that liberty that we're paying worth what we're getting in return, right? And for you, maybe it is, right? Because you're saying what I get in return is a 3 times more safe environment to live in. But for other people, it might be, yes, but maybe it's not worth it because what I'm doing is opening Pandora's box, where in 5 years from now, they might tell me only 1 kid per household, or whatever. I can't have more than 1 child, or whatever.
Yeah.
Because overpopulation is a problem.
I was worried that we'd get into the overpopulation thing, but like.
Oh, you're really thinking ahead.
Like the sterilization and COVID is a good thing, but no, I can't disagree with you. I'm not going to be facetious or ill faith and say that I disagree with that. I can see, I have faith in the fact that I don't think people are going in this direction in Western civilization. Like, I don't see that happening. I don't see us as a community that would tolerate that. Then again, I'm sure that there are communities that are in that situation right now that don't tolerate it, but that are stuck in it. I don't disagree with that. But what I will say though is that I think that the reason why I got vaccinated, and it's not going to be the same reason as to why you got vaccinated, but my reasons for getting vaccinated are because it's going to protect myself, it's going to protect my loved ones around me, and it's going to allow me to function in a healthcare system that allows me to treat people the way I want to. Those are my reasons to be vaccinated, and I don't think, and I don't think it's always a decision that's based on myself. My reasoning is based a lot on societal issues and my family and where I want us to be in 10 months. Am I going to be wrong? Am I wrong for thinking this? In 10 months, are we going to be fucking confined again and a 4th dose? Maybe, but I'll be comforted by the fact that I did what I thought was right at that time based on the available data and the evidence the strong evidence that was made available to me from a medical standpoint.
That's very fair. I think usually when I talk about this stuff with people, all I really care to accomplish is that people understand that there are costs that they're paying for their safety, right? So it's not like oh yeah, well, let's just get rid of COVID and then we'll see what happens after. Like liberty is a cost you pay for safety always. But anyway, I don't know if we have to wrap up soon. It's been an hour and a half.
I'm good. I'm
Um,
good. It's fine. Whatever you guys want to do.
Anyway,
If you guys want
okay.
more material, it's all good.
Well, yeah, we don't have a real strict time, but I mean,
No, I'm fine.
feel
I'm fine.
free.
I'm enjoying this. It's
Cool,
good.
cool. Me too. So I think maybe back to like technical talk a little bit. I'm curious. When you say, I think you said this earlier, correct me if I'm wrong, that the way out of this is if everyone gets vaccinated, and if they get vaccinated in a short enough period of time, right? Because if everybody just drags it out. Okay,
Yeah.
so is there research or some kind of basis that says, all right, given that the vaccine is X% effective, the virus spreads Y at a rate Y, and there's this many people, what's the minimum percentage of people that need to be vaccinated, right? That's a number you could probably hypothetically calculate. And what's the maximum or the slowest rate at which they could get vaccinated? And if they get vaccinated, if everybody gets vaccinated in one day and the vaccine is 80% effective, then you're still going to get variants and you're going to be back to square one, right? Potentially.
Probably not. 80% is the lowest number possible. I think if you look at modelizations, you're looking at if everybody's vaccinated, if 80 to 90% of the world's population is vaccinated within a year, then you're looking at herd immunity. And I think that's the reason why. The World Health Organization right now is starting to, because it's amazing. They're mid largest peak of the pandemic, right? Disaster everywhere. And I think 2 weeks ago, Jabrea said, we see the end of the pandemic in 2022, which is a pretty bold statement considering we're not doing so great right now, right? So I think that the general idea is that the modelizations say that if you have 80% of the population, 80 to 90% that is vaccinated
with
the amount
two
of natural
shots or boosters and
the idea is 2 shots. Whether or not they're going to need different shots with different, because we're already working on new specific Omicron vaccinations for people that haven't been vaccinated yet. Probably 2 shots. Probably, but I mean, I'm in no way a virologist, but those are the modelizations, and I think they see an end to it. I think a lot of the decisions that are being made now from local governments are to mitigate the immediate risk that we have now, like so that we just don't drown and have people die that aren't supposed to die. Because don't forget, we haven't seen the effects of COVID from a healthcare perspective yet. There's a buttload of people that are going to die of cancer that haven't been diagnosed, in 5 years, 6 years before they should have. Especially colon cancer. Colon cancer is the classic, it's a cancer that we can easily screen for and that we can easily treat from a curative standpoint. So a lot of these people are being missed right now because we can't do colonoscopy, right? But you've heard that before. This is nothing new for you guys.
Yeah, I mean, I don't, maybe you don't, we're kind of focused on Quebec, but when I think of like, all right, let's go all in on vaccinations and that's going to fix the problem. I think of Israel, right? And I mean, last time I checked, their third wave is just as strong as their first one, right? I don't know if you want to get into that. If you don't have information on that, that's fine. I was just curious if you'd had a look at that and how that kind of relates with this idea of let's just vaccinate to fix this, right?
There's a lot of mobility in Israel, a lot of people coming in and out, a lot of, they're in an area with extremely dense populations with a lot of, I think Israel is a good example. Israel and Canada and the US are good examples as to how to not vaccinate during a pandemic. I think that I think the reaction is, again, I said this before, it's visceral, is normal. It's what any government would have done, but that's not the way to go about it. The way to go about it is not to vaccinate your people as much as possible. It's to vaccinate everyone as much as possible. It's to spread out the vaccines, spread out the accessibility. I mean, why do you think all of
you
these
mean like all over the world? Just to clarify, like have Africa.
Variants are going to come from Canada. Yeah. Variants aren't going to come from Canada. Variants are going to come from.
We have one from France, right?
Sorry,
we just got one from France, apparently.
They
probably have people from Africa.
That's probably based from Cameroon,
sure.
Exactly, based in Cameroon. So these are where South Africa, Brazil, India, heavily dense population, poorly vaccinated, uneducated, low socioeconomical status. These are where the variants are going to come from. These are the people that we need to vaccinate now. And these are people that are going to be, I think, that have less vaccine hesitancy. for different reasons, but we need to give them access to adequate care, and adequate care in this case is vaccination. But yeah, I don't think that the Western world has been a particular example as to how to lead through a pandemic. They've been very good at leading their people through it, but look at the end result. 100,000 cases a day in France. We're not talking about Poland.
We don't care about the cases, right? The number of cases doesn't really, the number of cases don't necessarily matter.
But just like we don't care about Omicron cases because Omicron it may potentially be less severe than other ones. That's what we want to go towards, right? We want a lot of people to get the virus because typically when a lot of people get a virus, it weakens, right? That's what we want to go towards. That's the idea, right? But the problem is the sheer number, right? So we have a weaker virus, but still a very strong one when viruses, as far as viruses go. Now we have a lot of people that are sick. But we haven't, in January last year, we had 3,000 people a day that were ill. That was our peak. I was freaking out at that time. I was like, 3,000 people? Are you serious? Now we have 15,000. So we have 5 times more people. We don't have 5 times more hospitalizations.
Right. So the number of cases is maybe a bad metric to determine how a place is going, right?
It's a bad metric. But it's still, there is a correlation between the number of cases and the number of hospitalizations, right? It's linear.
But there's also the problem of creating variants, right?
Yeah, that's the main problem.
Okay. But I've also heard that there are reservoirs of animals that have the virus, right? So they can, are we going to vaccinate animals too?
No. Well, that's super interesting. That's actually, I'm surprised you brought that up because I'm not an expert. I'm not a veterinarian at all. But the fact that we have animal reservoirs now means that we probably will never be able to eradicate the disease.
Yeah.
So now we have COVID in deers. We're not going to, and there are there has
vaccine hesitant deer.
Yeah, no, but they have been mentioning a vaccination amongst animals, especially deer populations.
Don't they just kill them? I think they just end up killing all these animals.
I think it's hard to just kind of know if they have it or not, but whatever. Anyway,
Yeah.
But just stay away from a deer that sneezes next to the road, right?
But look, but if we can't get out of this, right? If deer have it now and it's never going to go away, are we just going to every year lock up to save the hospital? Is that the long-term goal? What's the...
No. So Perry, we have to we have to chill. All right. I mean, this has been 2 years now on a lifetime. Okay. And we have to stop acting like this has been forever. Second World War, 50 million deaths, 6 years. Okay. Just to put that in perspective, it's been 2 years for the pandemic. It hasn't been, and we're getting somewhere. We have treatments, we have vaccines, things are developing and the virus is changing. And I think my perspective is that we're probably going to end up being a flu-like situation where every year you get 2 shots, and those you get the flu shot and you get the COVID shot for the variant of the year.
But 1 second, but I don't get the flu shot, right? I've never gotten the flu shot. Are you saying it will have to be every year I will have to get the COVID shot?
Probably that as the vaccine weakens, the incentive or coercion to get the vaccine will be less.
That's interesting, right?
Flu shot.
That's interesting, Mass, because so every year people get the flu shot, but the reason for them getting the flu shot is never presented as you do it out of solidarity to protect the hospital system, right? But now it is okay.
From our stand,
I've never heard that argument before. Okay,
but it's probably not what's transmitted to the general population. It's interesting that you said that you didn't see it that way, but it's one of the reasons why we say to get the flu shot.
Okay, I think it's rare that someone under 30 takes the flu shot, right? I would say more people don't take it than do take it under 30.
Yeah, I would argue that's a problem, but yeah, I think you're right. Okay. I think you're right. Yeah.
Okay, so for you, we're heading into a situation where COVID is never going away, and that every year we'll have a booster. Okay.
And best case scenario is it weakens and it becomes like the flu.
Right. But the other point I wanted to just touch upon, when you say 2 years is a small time period, that's true. But for some people that are 3 years old, it's 70% of their life, right? So
yeah, but
I guess
maybe 2% of their eventual life. I mean,
sure. But I guess. But
I get it. Yeah, I get it. You're right.
I guess what I'm worried about is there is a chance we also do psychological or social damage to children. There's additional risk besides this myocarditis or whatever that putting all these measures is putting kids at risk long term, again, to save older people that have maybe that have lived a longer life already.
Yeah.
So
It's a slippery terrain, but yeah, I agree with you.
okay, but for you, it's still justified. This risk is still
But you're what you're describing is theoretical, right? Whereas what I'm describing is concrete. I'm telling you that the people are going to die. The 60-year-olds are going to die. You're telling me that maybe the kids are going to have a hard time, sharing.
No,
but
I mean,
it's true though. But what I mean is,
yes.
I'm saying this as a joke, but I'm trying to exemplify the fact that they're going to have a hard time with social interactions. That's the concern, right? Is that
cognitive tests also?
I don't think cognitive is going to be an issue. I think social interaction is the main one because they're not going to daycare and whatnot. But I agree. Well, what I would ask you in return is, do you think that, or have you been under the impression that we haven't been aware of this issue?
I think from my perspective, it seems like the ultimate goal is get rid of COVID no matter what the cost. That's the perspective I'm getting from a lot of the that's my perspective, I guess, from a lot of the justifications that are given for the measures that are being forced.
No matter what the cost?
It seems that way.
I mean, we opened the restaurants back up as soon as we could have. We let people go back to sporting events. We had 20,000 people in the Bell Center a week before we had 10,000 cases.
But I mean, yes, you're right. But
I think they're aware of it. Is what I mean.
They surely are. But the communication of this whole thing is tomorrow we're closing things on New Year's Eve because COVID is too high. We don't care about the economic impact. We don't care about social interaction between people on a holiday season. This is what we're doing. Yeah, that's my perspective that I get from the communication of what's going on.
How do you want us to take the government seriously when they tell us, well, we're going to lower the amount of people that can get together in a meeting, but only starting December 26th? Like, how do you want the government to take us seriously from with that point, right? But that's aside the point. I just wanted to mention that. But I agree. I think that what you're mentioning is should definitely be one of the guiding principles as to how we go about this going forward. I think that people were saying, I think we thought a lot about, high schoolers and all the, when they missed their prom last year. We spoke about that abundantly. I don't think that was completely forgotten. I think that we are aware that there is an effect. Initially, we were just focusing so much on the elderly and their tangible effects of COVID. I think more and more we're being aware of the effects on teenagers and on young children, and I think that we apprehend the effect on the very young, right? The 1 and 2 and 3 year olds. I think that mostly the 2 and 3 year olds that don't go to daycare. I think that's I don't disagree with you. I agree with you, and it's a genuine concern of mine. I'm not a specialist in any way. I'm talking to you as a dude that's gonna have a kid. I agree with that. It's something that would concern me if I had a child that was 2 years old right now. Then again, I didn't go to high school. I mean, I ended up I didn't go to daycare. I ended up okay. But I think that from a mass perspective, definitely it's something that we should be looking at very, very closely. More so than and this is a very personal take on this, restaurateurs and all these things, we were pumping money into a lot of businesses and stuff to help them stay afloat, which is fine, but I think we should be pumping a lot of money into what's going to happen to our next generation, and what are the effects of COVID going to be on them in the long term. I 100% agree with that.
Do you think
go ahead.
I think that may be a strong argument towards unjustifying some of the measures, especially for younger people. Go ahead. Sorry, Carlos.
Did you have a follow-up, Perry?
No, that's good. I had a different question.
Yeah, me too. I'm curious. Do you think that the vaccine passport system that Quebec has implemented right now should stay indefinitely, or should it be something that has a very strict ending condition? Was it a good idea? Should we? I think
it was an amazing idea. I think it was very well played out. I think that our passport system is amazing compared to other passport systems in the world. In the States, it's a little card that you write on. I mean, come on. In France, it's also a little bit different. I think ours works very, very well. I think it's difficult to falsify.
I think there's, just to interrupt you with, I think I
Yeah.
was thinking about this, like, why does the US have this little piece of paper that someone wrote on in pen?
Yeah.
I don't think it's just like incompetence, right? I think they believe that, you know, a medical record shouldn't be something that's stored in some database. You have no idea where it is. And I think that is almost a feature of it, that it's so destructible and kind of.
Well, so, but they have the database though. They do have a database though in the States, regardless as to how they document it. For us, I personally think it's a structural thing. I think it's an infrastructure. It's too big of a. The States is too split up. I think that's the main issue.
Okay,
in the States.
yeah, that's fair.
But my take on the vaccination process and the not the vaccination process, but the passport is that I don't think that people and again I expect a lot of blowback from this, but I think that the people that made the efforts and that tried to get us out of this and that got vaccinated, I don't see why other people who refused and who went against the current should be allowed to benefit from or to reap the benefits of the people that actually made the efforts. Should the vaccination passport be indefinite? No, of course not. I don't think it should be indefinite. I think that this is a temporary measure we can't segregate and discriminate against people forever. I mean, because it is a form of discrimination, the vaccine passport. It's something it's a decision that was made it's an extreme decision, an extreme mandate in a extreme situation justified by extreme measures and extreme conditions. I don't think it should be indefinite. No, definitely, absolutely not.
But you touched on something interesting. So you're saying that first of all, you said that you don't think people that didn't get vaccinated should reap the benefits of the people
who made the efforts.
But what about when
they're going to reap the benefits because of natural immunity? But okay. I don't think that they should. I don't think that because things are doing better now. We have less COVID. Things are going well, but we're still at risk. I should be allowed to go to the restaurant too. But
it's interesting because I think right now we've shown that even if you are vaccinated, you can still spread the disease. Mm-hmm. So I don't see the benefit of limiting people that are unvaccinated that spread the disease as much as people that are vaccinated.
Because because when you're vaccinated, you have a lower risk of having the disease. You have a lower risk of having a significant viral load, and you have a significantly lower risk of spreading it.
But it's 30%, right?
How come cases are higher now than they were when there was almost no vaccination? That doesn't matter.
Because I think it's like a 30% thing, right? It's not something substantial.
The first thing is we blew up because when the cases started to blow up, we were completely deconfined, right? So when things started, we were, like I said, I was at the Bell Center, 20,000 people. So it's only normal that if we're in situations where everything is opened up and the new variant comes in and there's a lot of vaccine resistance, because there is vaccine resistance with the Omicron.
But it's like 10%, right? We're like 90% vaccinated in Quebec.
We're 80% vaccinated, 80% right. Vaccinated.
So if 80% of the people had a 90% immunity to COVID.
It's not 90% with the Omicron, it's 30% against symptomatic disease.
So that means that the vaccine doesn't really protect you from COVID anymore.
It's 75% with a third dose.
But no one has a third dose, right? I mean, people are getting it now.
Well, it's coming now, yeah.
Yeah, but what I'm saying is
26% I think today?
For a long time, people with the vaccine or without the vaccine were spreading COVID at relatively the same rate. From the time Omicron came out to the time the third dose was administered.
No, we still have studies that show that their viral load and their shedding is lower when you're vaccinated.
Okay, so you're saying if I'm unvaccinated, I have a higher chance of
higher risk of spreading. Yes, you have a higher risk of symptomatic disease of spreading. Your R of spread is higher than if you're not.
And on that subject as well, so I'm in Switzerland right now, and here you can get a passport if you show that you've recovered from COVID. I don't think that's the case in Quebec, is it?
No.
So
it was the case where initially you were allowed to have the passport if you had a documented case of COVID and 1 dose. Now we've changed that to 2 doses. It's an interesting discussion. We know that the natural immunity, we touched on it a bit before, natural immunity is not as strong as we thought it would be, or for as long as we thought it would be. Now, a lot of, we're recommending a 3rd dose for everyone. There's a little bit of hesitancy for people who have gotten the disease, got 2 doses for a 3rd dose. There's still a little bit of hesitancy. And I'm not sure where I stand on that either, because I just don't have the data. I don't have the information to give you. I'm not going to lie to you guys and say everybody get the third dose, get vaccinated. That's probably what's going to end up happening, but I don't have the data or the evidence to support that. I know that definitely immunity, naturally involved immunity definitely doesn't last more than 6 months. Not at a significant level.
But
So
the vaccine immunity lasts longer, you're saying, or
vaccine
the same?
immunity is approximately 8 months, if you give or take.
So it's the same. It's roughly the same.
Sorry, well, it depends. We don't have exact curves, but we know that it's pretty similar. Pretty similar. But what we do know is that the immunity, actually, no, sorry, the 2 vaccinations builds a stronger response than a single, than if you just were exposed. So if you were doubly vaccinated, so if you got the disease, all right, you're not as protected as if you were doubly vaccinated. I don't know if that makes sense to you guys. Does that make sense? Yeah. And now, lengthwise, I'm not exactly convinced. And the other reason why it's spread, yeah. So the other reason why we have so many cases now is because of vaccine resistance. It's unfortunate, but it's true. Right?
No, but I mean, for sure, a lot of vaccinated people are infected now, right?
A lot.
I mean, it doesn't add up if it's 90% vaccination.
No. A lot.
Yeah.
Yeah.
So that's why, like, I feel like there's some. It's not black and white to me. Like, it's not 100% of people need to be vaccinated. You were saying that intervention should be as minimally coercive as possible, right? So
yeah,
there's some number of vaccinated people combined with some efficacy and time period of administration. That's optimal, right? But I guess
and time, right?
Yeah.
You need to look at immunity as a function of time and build up a strong enough immunity in a short enough period of time. And no matter how you get that immunity, I think is fine.
Yeah,
and it could be that 100% vaccination is not enough. Like, I don't think we know that.
Right, it could be that immunity
effective,
may have to pass. Immunity may have to come through by 2 vaccines and 2 infections. Eventually it'll come, or at least immunity will be strong enough for us to weaken the vaccine naturally, to weaken the virus naturally. I think that I think we should use the least restrictive manners possible to protect autonomy as much as possible, especially when promoting vaccination. The only thing is, I think many of these low coercive methods have proven to have reached their limitations at the moment, and I think that that's where we're at now. And by least coercive, I mean I don't mean vaccine passports and some. I think vaccine passport is a pretty coercive. Sorry about that. Method of pushing for vaccination. I think it's a strong one. I mean it's a openly discriminatory, accepted. Because I mean we can argue all we want. Vaccine passports are widely approved and accepted in Quebec. When you look at the if you look at the sondage, 70% approval for vaccine passports, 70-80%, which is very significant. I think we've reached our limit as to what we can do to force people to get a vaccine without a forceful mandate. I don't think we're ever going to get there in Quebec. I don't think we're ever gonna if ever we do, I'm happy to come back on and chat about it. I don't know where I would position myself for a forceful mandate. If we're talking from a more, metaphysical and just, philosophical standpoint, I think it's justified. From a human standpoint, if I take off my lab coat and we chat as, a bunch of guys around a beer, I'd probably say, well, I have some issues with it. I'm the same issues or the same concerns that you guys have brought up, on many occasions.
Cool. Yeah, that was good. I don't know if Carlos have any more questions.
Of course I do, but I think we should let people.
I'm happy to come back on if you guys have
digest
more
that. Of course we do.
Come back on.
I think we can talk for hours, but more. But maybe it's. I think that's a good place to end it. I don't know. I think to sum up, Mass agrees with everything we're saying. I'm joking.
I want to thank you guys for making this an easy and pleasant experience for me. It's oftentimes, don't feed the trolls. It's hard for me to kind of be on social media and to be a bit of a public figure and a bit of a someone who tries to be a champion for vaccination and for COVID prevention. despite my biases. And I think we had a good discussion. I think that a lot of good came out of it, and I'm happy to come back on and to maybe have more difficult discussions with some other guests. We'll see.
Oh yeah, sounds
Absolutely.
great. What's your Twitter?
Sorry,
What's
it's
your-
at Eyes Upon EM.
There we go.
We're gonna, yeah, maybe you want to also, maybe you want to promote other ways people can find you. For example, television, radio, perchance.
Listen, if you guys want, man, my Twitter's at Eyes Upon EM. That's EM as an emergency medicine. And if you guys want to catch me on the Gal the Main Cat set, it'll be on TVA a couple times a year. Last few seasons, I've been putting my face on TV.
Wow.
Perfect. Thank you. Yeah.
All right,
So
man.
maybe our most famous guest is on there right now. So thank you very much, Max.